neurodegenerative disease. Please.
Thank you for this opportunity to talk about brain imaging biomarkers. I'm a neurologist at the University of Siena. I've been working on imaging biomarkers for probably 30 years now. And this is a sort of long process, which is also part of this of the Tuscany Health Ecosystem project, specifically on the precision medicine project of SPOC6, in which at least I'm focusing on on trying to develop new biomarkers, imaging biomarkers, which could be good and useful for the single patient, the clinical use. When we talk about advanced imaging, I'm talking about something which is in a way related to the clinical use. So it's using mainly MRI, sometimes PET, but clinical machines. So something that anybody can do in the clinic, in their hospital. But in general, when we talk about MRI, we talk about something which is useful for diagnosis. It's a radiological tool, and eventually related to the experience of the radiology. When we talk about something which is quantitative, it can be, something related to a quantitation of what's happening in the brain. We're talking about something which is a bit different and can be related to exploring new ways of neuroanatomy, assessing function of the brain, understanding eventually disease mechanism, and of course tracking disease progression and monitoring treatment. So something which is more complex, and in this way could really be biomarkers that could be used for several situations in several conditions, and not only just for making or improving diagnosis, which is of course very important, but there are all other aspects, especially in neurological disorders, that could be as important as well. In order to do something like that, we have to develop something which is, very much based on in informatics, on computers. And in order to do something like those you see there, automatic lesion count and volume in the brain, eventually try to quantify atrophy, to measure what we call macrostructure, so something that you don't really see as a pathology, but is underneath there in our brain, and eventually, even more fascinating if you want, structure and measuring structural functional connectivity of our brain. Today I will focus only on lesion count, volume, and brain atrophy for two reasons. First of all, because I don't have the time to do all of them, but also because they are those which are much more close to the clinic, which is our goal in our precision medicine project. Lesion quantitation is something that we want to, I'm going to go very fast on this, is something that we want to do. I mean, we want to identify lesions and count them and eventually get the volume, but also we want to monitor them and try to understand whether they are slowly expanding or enlarging or resolving, shrinking, disappearing, whatever. And we want to have a number of this because this is something which is much more objective. There are several software out there working quite well on this topic. This is one software we developed recently. It's called Bianca, and is actually very good on assessing vascular lesion and multiple sclerosis lesion. This is I don't go into detail there, but I mean it's a comparison of Bianca with best performing other software that you can find in the field. And the beauty of Bianca, which is actually using a machine learning approach, is that this can decrease the variability of what we can get automatically, basically, by 20 or 30% compared to other software. One thing Bianca is also using is the segmentation, the subtraction imaging after segmentation approach. What we do, we subtract time 1 from time 2, as you see there, and in C you have the difference of the two. You see very well the lesion which you can quantify. I mean, it's a very simple approach, very good, and very fast, thanks to the artificial intelligence, to the new approaches that we can use, particularly to make all this much faster than they were before. Even also, of course, more precise. And this is what you get in a tumor. We heard about tumors before. These are two. This is one tumor which, as you can see, is quite large. And time 1 and time 2, actually, you see sort of improvement there. I mean, decrease in size of the lesion. But if you actually go much more in detail there, you see that it's not just a decrease. It's just, I mean, the red, the blue that you see is a decrease, but the red is an increase. You have an increase within the lesion, and an increase also in the small lesions that there was in the other hemisphere. It's something that you can not only see much easier in this way, but you can quantify. Together with the approach on focal lesion, what we want to do when we look at the several neurodegenerative disorders is to actually be able to quantify what we simply call atrophy, but it's a devastating loss of tissue in our brain, which is, you see quite easily there. We are talking in this situation is a patient which was I think around 50 years old compared to an healthy control, on a patient who has a disease which is not supposed to be a neurodegenerative disease, at least it was not supposed to be, which is multiple sclerosis, is the demyelinating disorder. What we know today is that the neurodegeneration is actually very prevalent in multiple sclerosis, also in the early stages of the disease, and you see there the output of this after 20 or 30 years of disease. Is big atrophy, which can be quantified. We made 25 years ago now this software which is called Sienna, which in this situation doesn't stand for the city but for structural imaging evaluation normalized atrophy. This software has been used quite largely in the field, also because it's part of this software library of the University of Oxford. And it's actually very good on quantifying the whole brain damage in terms of volume for the whole brain, the total brain changes over time, for example. One thing that we are doing right now is to evolve this software by, this is now the latest output of Sienna, which is XL, which doesn't mean extra large, but cross-sectional and longitudinal, in which we can actually quantify all different regions of the brain, whatever region you want. Lobes rather than, hippocampus, which is very important in Alzheimer's disease, rather than thalami, which is important in multiple sclerosis. So frontal and temporal lobes for frontotemporal dementia and so on. So basically it can be used in every single neurodegenerative disorder in order to quantify regions, which is important, as I said before, for both diagnosis, for example, frontotemporal dementia, rather than to see disease progression eventually check this structure during a treatment to see whether the treatment is actually doing the job or is not. One thing that we are doing also is right now is to apply this to spinal cord, which is important for other diseases, LS, for example, and try to see how a teeny region like the spinal cord can change over time with this what is called Siena, in this case, spinal cord. All this software are, of course, fully automated, and not most of them, at least the oldest version, but in the future there will be the new version, are available online for whoever actually wants to use it. And what we did, and we are doing also during this project, this is one of the most important goals, is to actually apply artificial intelligence to this imaging analysis process in several ways in order to, first of all, speed up the process. When we made our Siena 25 years ago, one single examination was lasting 3 or 4 hours, which you can understand I mean, it's impossible for radiologists. They don't want to even know about it. Now it's 3 or 4 minutes, which can be done during the examination. And the other point is to not only to make it faster, but to make it better, in the sense that the variability, thanks to deep learning and machine learning approaches, have been it is now much smaller than it was before, and this allow us to try to include these biomarkers in the clinic for single patient level. All this software have been very much used to find a group level assessment, for example, for clinical trials. But what we are proposing right now is to use at a single patient level in order to make quantitative report in different situations, which is not, again, is not only diagnosis, but also treatment response or disease progression. What we are proposing, and this is almost done, is part of the project, is a web-based assessment of this brain image biomarker, which means you don't need to have your own lab. You can do it at home, in your laptop. Like you use ChatGPT. You just get login, password, do your job, or we're doing for you if you're not able to do it, or we teach you how to do it. And in this way, we are trying to include this in the, this sort of a new way of single patient assessment for brain imaging, neurodegeneration and neurodegenerative disease, at the clinical level. This is done in Siena, it's a joint lab between a spin-off that we created years ago and my university lab. These are the people, and at least some of them, in a recent meeting, and thank you for your attention.
Okay, thank you so much. Very interesting. Any question from the audience? I have just a curiosity, if I may. I saw that you used or are using also deep learning techniques, which in some way are supervised techniques. From your perspective of neurologist, it is enough to believe on what the results of the network provide you, or do you feel that something else you could need? I'm thinking about what today is called explainable AI, so to better understand. Since this topic is still, at least for me, a bit not focused, I'd like to know if you have some opinion about that.
No, absolutely. I mean, you're completely right. there is one difference anyway. I mean, what we are using the artificial intelligence for is not to have an output, but to increase the performance of the analysis. So to make it faster or to decrease the variability, which is different to have an output based on artificial intelligence. We just use in the model, in the pipeline, to have a better performance of the software. Then, the interpretation is in our interpretation. Anyway, this is for our part. In general, I think exactly the same thing, in the sense that the interpretation of the data must be always in the hands of the doctor who actually knows the patient and knows what we are talking about. It was actually in my slide before, I don't know if we can, it was one of the last, oh no, it's not there anymore. It was in the web-based assessment. The last line was data interpretation, which is always in the hands of the patient, of the doctor who knows the patient, and who knows the pathology, the comorbidity, and so on.